Assalamu alaikum wa rahmatullah. Welcome back to the second part. And when we are talking about the neuropathic pain, we can classify it into episodic and continuous pain based on its clinical presentation. In episodic pain or episodic neuropathic pain, the pain usually lasts for very short duration and disappears. So there is sort of periods of time where there is actually no pain at all, or pain-free intervals. And the length of this pain-free intervals, it varies, depends on the severity of the condition. And the pain is usually sharp, lacerating pain, and it lasts for, as I said, very short duration. In continuous pain, it is actually constant pain. So the pain might increase or decrease in intensity, but all of the time there is pain. And based on this classification, episodic pain, we will be talking about trigeminal and glossopharyngeal neuralgia. And continuous pain, there's different types of pain and different based on the etiology mainly. So we will be talking about painful traumatic trigeminal neuropathy. We'll be talking about neurotic pain related to infection or inflammation, and we call this neuritis. So there's inflammation of the nerves related either to infection or inflammation. Persistent idiopathic facial or pain, or persistent idiopathic dentoalveolar pain. It depends where the pain is located. And burning mouth disorder or burning mouth syndrome. Please note that here I have used the most recent terminology terms that are suggested by the Pain Society. I'll be presenting the previous or the old names when I talk specifically about each disorder. As you have noted, so continuous pain can be peripherally mediated, so there's a problem or damage within the peripheral nervous system, and they're centrally mediated. And here I'm not talking about the central neuropathic pain. I'm not talking about brain tumors or cerebrovascular accidents or demyelinating diseases or disorders that occurs within the central nervous system, but I'm talking about the peripheral nerve that lasted for a long time or long duration, leading to rewiring, as I described before, rewiring of the central nervous system, which made the pain persist. So example of that is post-herpetic neuralgia, or post-herpetic neuropathy is the more, let's say, acceptable and more recent term. So things will become clearer in the coming few slides. Let's talk about the episodic pain, the trigeminal neuralgia. The reason why why it happens is usually the irritation and demyelination of the root, the trigeminal nerve root, caused by compression, and usually it is the superior cerebellar artery that compresses on the trigeminal nerve, leading to myelination. Of course, it can be this, and this is the most of the cases, and we call this primary trigeminal neuralgia, or sometimes it could be secondary to other neurological disorders, like presence of tumor maybe in the cerebellopontine angle or in the area close to the trigeminal nerve, and this compression might lead to myelination. Also, it might be related to demyelinating disorders like multiple sclerosis, for example, which induce demyelination of the trigeminal nerve and will give symptoms exactly similar to trigeminal neuralgia. In trigeminal neuralgia, we need to figure out the cause of it. So when the patient is presenting with clinical features typical for trigeminal neuralgia, we need to figure out whether it is related to a tumor, whether it is related to demyelinating disorder, or is it related to compression by the superior cerebellar artery, and this is why we do MRI for any patient presenting with symptoms similar to trigeminal neuralgia to know the exact cause of the trigeminal neuralgia. How it is presented clinically, it is, as I said, it's an episodic pain, so the patient have electric shock, sharp pain, and we are talking about trigeminal neuralgia, so it's affecting the trigeminal nerve. It could affect the ophthalmic branch, it could affect the maxillary branch or the mandibular branch, and most commonly the trigeminal branch is affected, the mandibular branch is affected. Some patients have two, like the maxillary and mandibular, both of them are affected. So it is presented as sharp-shooting pain. The patient, if he touches his lip, this would trigger a pain. Even sometimes walking would trigger a pain, or a breeze, wind breeze would also triggers the pain. So the patient usually avoid touching the area, and when the patient had this sharp-shooting pain, the patient tends to rub the area, trying to relieve this pain. This is a common finding of all patients. And the trigger zone, we call it the area where, if touched, it will trigger the pain. So the trigger zone can be like the lip, as I said. Sometimes it can be within the dental area. So like when the patient touches his tooth with his tongue, he would have pain. And actually, many patients, when this is the case, when the trigger zone is within the dental area, they go and see the dentist. Sometimes the trigeminal neuralgia is not presented in, let's say, in this typical clinical presentation. The patient might have sort of prolonged pain, might have a burning sensation, or neuropathic like numbness, or paresthesia. And paresthesia means there is tingling sensation. It's not anesthesia, where there's a complete loss of sensation. It is paresthesia, where there is sort of a tingling sensation in the area. And later on, the features become more, let's say, typical of trigeminal neuralgia. One of the features of trigeminal neuralgia is that when you touch the area, this would trigger a pain, and if you touch it like immediately afterward, this would not trigger any pain. So there is sort of pain-free area before you can trigger a second attack. So this is a feature of trigeminal neuralgia that would help in the diagnosis. So we call this period a refractory period. When the trigger area is within the dental region, and the patient usually, as I said, goes to the dentist should, examine the tooth, do vitality testing, take periapical radiograph, and if there is no evidence of dental pathology, you should not proceed with any dental treatment. And I've seen patients who have the teeth extracted in the whole side, like up to the central incisors, because the dentist, did filling, the pain persisted, then proceeded to RCT, still the pain is there, he did extraction, or he did RCT for the next or the adjacent tooth. And some patients might present with the RCT to the whole upper quadrant of the jaw, because the dentist thought it is pulpitis, or it's a irreversible pulpitis. And this is, a misconduct of the dentist. This is actually the dentist can be sued for this, for providing unnecessary treatment. So for you as a dentist, if the patient came complaining of sharp-shooting pain, you do your investigations, vitality testing, radiographic investigations. If there is no evidence of dental pathology, do not proceed with a dental treatment, and think that there is a possibility it might be a neuropathic pain, and you need to refer the patient for specialist to confirm the diagnosis. One of the warning signs about presence of central pathology, like a tumor or multiple sclerosis, is when the pain is bilateral. Usually the pain affects one side. Very rare instance it is bilateral, but when it is bilateral and mainly when you have a young patient, think of multiple sclerosis. Rule out dental pathology. If there is no dental pathology, refer the patient to the neurologist, because there is a high possibility that there is a central cause for it, like brain tumor or multiple sclerosis if it is bilateral and if it is affecting a young individual. How do we treat patients with trigeminal neuralgia? Medication is the first line of treatment, and the best medication is carbamazepine. Most of the patients respond to carbamazepine, and if the patient cannot tolerate the medication, of course there are other options, but if like gabapentin and other anti-epileptic medications, if the patient did not respond to medication or cannot tolerate the side effects of these medications, surgical treatment is indicated. And the surgical treatment is called decompression surgery, where the compressing artery is separated from the nerve, and usually a pad of Teflon is placed in between to prevent the rubbing of the artery to the trigeminal nerve. And usually, symptoms are relieved by this surgery, but sometimes the patient cannot tolerate the surgery, particularly in elderly patients, so other options are available like rhizotomy. And in rhizotomy, it can be done under local anesthetic. The sort of a big needle is inserted intraorally to reach to the root of the trigeminal nerve, and the trigeminal nerve is cut there. It can be cut using radiation, or can be cut using injecting glycerol material, which has a neurolytic effect, or thermal rhizotomy. By heat, the nerve is cut, or part of the nerve is cut. This procedure can be repeated. It is effective, but it has a high chance of complications, including numbness. So the patient would lose the sensation in that area, but he would not have pain. Gamma knife is a new technique where gamma rays are focused at the point of the trigeminal root area to again damaging that branch of the trigeminal nerve, and then the patient would not have any pain. It is safe. It is easier than doing decompression surgery, and indicated for patients who cannot tolerate doing or going under GA. So this is about the trigeminal neuropathy or neuralgia. Glossopharyngeal neuralgia is much more rare than trigeminal neuralgia. I've never seen a case of glossopharyngeal neuralgia, but there are several reports about glossopharyngeal neuralgia. The same pathophysiology, compression of the nerve, the same presentation, but the differences in the area. So usually the patient would feel pain in the pharyngeal area, the posterior part of the tongue, and sometimes the pain is referred to the ear and mastoid area. Again, it is less severe in intensity than trigeminal neuralgia, but the patient would feel pain in that area, in the pharyngeal and soft palate and base of the tongue. Treatment is similar to trigeminal neuralgia. Medication, if did not work, surgical option is available. So this is about trigeminal neuralgia as an example of episodic pain. Of course, other nerves within the cranial or cranial nerves can be affected, but these are the main ones: the trigeminal and glossopharyngeal. The next part will be talking about continuous neuropathic pain. See you then. Bye-bye.